let's first know how to diagnose PDS, because it's crucial, because many of them are going to be converted to the pigmentary glaucoma over a period of time. It's rather simpler and easier. You must look for the Krugenberg spindle as a routine. You must also look for the radial transillumination defects as shown here. Of course, this is by the retroillumination. And remember that if it is a heavily pigmented eye, you may not get these transillumination defects in an early patient. And this is the key finding. There is posterior bowing of the mid-peripheral iris. And this is what is the factor responsible for everything that is happening, and is important also in the management part. Angles are wide open and heavily pigmented, and the degree of the pigmentation quite correlates with the severity of the disease. Zentameyer's ring is the interacted lines of the pigments on the posterior capsule peripheral part, as shown here. These are the interacted lines here. And if you want to detect them, you need to dilate the pupil and examine the pigorium. You may also get lattice degeneration in about 1/3 of the cases of the pigment dispersion syndrome. The mechanism of the pressure rise in the PDS is quite interesting. There is a posterior bowing of the peripheral iris, and that leads to the friction between the iris and the zonular fibrils of the lens, leading to the release of the pigments, and these macrophage-laden pigments then obstruct the trabeculum and of course subsequent damage to the trabecular meshwork. It has to be differentiated from the conditions that can lead to the liberation of the pigments and deposition of the pigments, like uveitis, sulcus fixated IOL, and so on. And it also needs to be differentiated from pseudo-exfoliation syndrome, which I am going to talk about in a short while. However, remember that pseudo-exfoliation syndrome is seen in the older subjects, and there are whitish deposits in the anterior chamber. As far as the management of the pigmentary glaucoma, pilocarpine is a drug which I would like to talk about. Pilocarpine reduces the posterior bowing of the iris because it is going to pull the iris away, and it will also help in exercise-induced pressure rise. But these are the young subjects, and the tolerance in these myopes may be an issue. And it may also increase the pigment dispersion. If you use pilocarpine, there will be more liberation of the pigments and may increase the problem. So what we can do is that a good drug like pilocarpine should not be discarded completely. For a situation like management of the PDS, maybe you can measure the pressure before and after 30 minutes of exercise routine, and then if there is a significant rise in the pressure which is exercise related, you may use pilocarpine in a very low concentration, like 0.5%. Before exercise. Of course, the other drugs like prostaglandins, beta blockers, and carbonic anhydrase inhibitors are always available for the use in case there is any issue regarding the use of the pilocarpine. LPI in management of the pigmentary glaucoma is important. As I said, the posterior bowing of the mid-peripheral iris is the key finding. It relieves the posterior bowing of the mid-peripheral iris, but once there is glaucoma or a glaucomatous damage, then this will not be effective, and you may have to sort out the other measures. The other options are argon leather trabeculoplasty, because less energy is required. It is a heavily pigmented trabeculum, and maybe with mitomycin C can be used. But please remember that these are the myopes usually, and there is a risk of the hypotonous maculopathy in these cases. Another condition which I would like to talk about is pseudo-exfoliation syndrome, the pseudo-exfoliation glaucoma. Again, 1/3 of the cases of pseudo-exfoliation syndrome will be converted into glaucoma. And the commonest cause is secondary glaucoma. It varies from one region to another. Maybe in the southern part of our country, we get more cases of the pseudo-exfoliation as compared to what we get in the northern part. It's seen in the women around 50 or beyond. Diagnosis is detection of the exfoliation material. You all know about the 3 zones, and there is a clear intermediate zone, and if you want to identify them, you must use low intensity illumination by slit lamp that makes the detection of these white deposits easy. Transillumination defect. Now contrasted to what you get in the pigment dispersion, here you do not get radial defects, but you get defects at the margin. And these transformation defects, they actually appear like a moth-eaten appearance. And you can get exfoliation material deposited over the iris, of course corneal endothelium and the temple also. Sempervesi line is another thing that you should look for. And if you are dealing with a case of pseudo-exfoliation syndrome, please don't forget to look for the levels of the homocysteine and abdominal aortic aneurysm that may present in some of these cases. The mechanism of pressurized with pseudo-exfoliation is basement membrane alteration is the basic pathological change. And then there occurs rubbing between the iris and the exfoliation. Exfoliation material is getting deposited over the lens. And when there is a rubbing between this material and the posterior surface of the iris, there occurs disruption of the iris pigment epithelium and the pigments, and that is clogging the juxtacellular tissue and cellular. Well, coming to the management part, there are a few issues related to the management of the pseudo-exfoliation. One is that despite high pressure, these patients may be asymptomatic. Second issue is that the 24-hour characteristics are worse than the primary open-angle glaucoma. You may get a larger diurnal fluctuation. And the third is the issue of the dilatation. If you want to dilate this pupil, then there is a release of the more pigments from the iris. And further, there is a poor response to the medication. How are you going to handle this? Despite high pressure, patient may be asymptomatic, suspect glaucoma in pseudo-exfoliation. All cases. Do your water thinking, do your diurnal variation. Because there is more advanced damage, you need to know the pressure heights, the peak and the trough of the diurnal curve. And for the dilatation, you can always give cover by the astazolamide before you take them for the surgery, like cataract alone or in combination with therapy. What to do for the poor response to the medication? It is just like primary open-angle glaucoma as such. Prostaglandins and beta blockers make the good choice. Avoid pilocarpine, especially if there is posterior subcapsular cataract. A better response to the ALT is expected in these cases because of the pigment deposits. Maybe with or without mitomycin C can be done. And a combined approach for the cataract and glaucoma can be considered because they may have cataract also. They have big zonules, so you have to be very, very careful. We are still looking forward to a drug that can eliminate the formation of the exfoliation material, because then our problem is solved as far as pseudo-exfoliation. Thanks for your kind attention.